I'm Art Hengerer, a member of the planning committee for this virtual symposium. To open today's session, I want to begin by sharing my personal story derived from years of offering support and guidance to many clinicians in obvious distress from burnout, substance use disorder, and their work environment. Reflecting on some of those clinician stories and maintaining my own resilience and well-being may help to put today's presentation into perspective for many of you in attendance. My medical career was an academic otolaryngologist, department chair and resident program director for 27 years. During those years, I faced times where my workload in patient care and non-aligned system requirements led to some poor decisions about my health and well-being that negatively impacted my work-life balance. I endured several periods of burnout and stress that at the time, I only felt the need to become more resilient, and well-being was not emphasized. As a result, I didn't understand the risk or seek support with my first marriage ending in divorce. I now understand was in large part due to my selfish decisions and the work commitments. 16 years later, my second marriage required an extended period of time caring for a spouse who ultimately lost her life after a long battle with cancer. And again, challenged my resilience and well-being. These two periods of my life made me realize how fragile I had become and the potential risk to myself and my patients. Fortunately, this changed the focus of my career to one committed to address clinical burnout and wellness. I became the chair of a state medical board where I saw many clinicians who did not seek help for their issues, often due to fear of potential consequences. It drove me to a commitment to change that stigma of fear, to care for oneself and assist others. Becoming the chair of the Federation of State Medical Boards, I used the position to guide changes concerning mental health and substance use disorder questions on state medical licensure applications. So positive answers is only required when currently impaired. Although it has driven change, there's more work to be done. Presently, I'm serving on the Federation of State Physician Health Program Board and the National Academies Collaborative, allowing my journey to continue as there is still more work to accomplish. This quote puts clarity for me to the reason to continue the journey. No one is okay right now. Everyone is a varying degree of not okay. We all are carrying some level of trauma. If that quote is correct, then what have we accomplished to date with the collaborative to address this degree of not okay? I know that Dr. Dzau and others will be addressing that in detail. Other factors we all recall were early in the pandemic, first responders and healthcare workers were viewed by the public as heroes, but over time this shifted to disillusionment with developing harassment and violence directed towards them. Society has been challenged with the increased awareness that the pandemic had on diversity, ethnicity, and inclusion issues, and managing health delivery and the work environment. It is the accumulation of many factors that have played heavily into the Great Resignation and the present challenge facing many of the organizations and institutions represented and participating today. The problems are not unique to healthcare and affect many parts of society, but our work has a critical and at times life-saving impact on the welfare of our patients and ourselves. Dr. William Osler said, "There is no more dereliction to care than a clinician's duty to their own health." Therefore, we are here to find solutions for these questions and barriers that are affecting all the facets of healthcare. We are indebted to the three institutions highlighted today who will discuss their program efforts and progress in their journeys to break down the barriers and find the answers. Everyone has a role to play to find the solutions at this time. Thank yous go to the National Academy of Medicine staff, the Planning Committee, and members of the Action Collaborative for all their efforts organizing this symposium. We are pleased you joined us today and look forward to many informative presentations and lively discussion groups that will challenge us to identify the barriers and solutions. I thank you, and we'll now turn this over to Dr. Dzau.
Art, thank you so much. And thank you for sharing your personal story. You know, your comments were so moving, touching to all of us. And of course, your commitment to this area is really, really appreciated. I would say that your story just shows that this happens very frequently to many of us. In our generation, that is yours and mine, and I can certainly tell you, Daryl Kirsch and Tom Nasker, my co-chairs, they all have given stories, like I did too, of a similar nature that we didn't recognize at the time was burnout, but looking back clearly that we were struggling in our work and not being able to do what we want to do, given the circumstance, particularly of burnout. So thank you very much indeed. So I'm gonna make some short remarks. I'm Victor Dzau, the president of the US National Academy of Medicine and the co-chair of this really important initiative. Today we are gathered to talk about the issue of clinician retention era of COVID. You know, we've been talking about this since, I guess, the end of last year, very eager to come out and really make a difference to the workforce who's really in many ways struggling, suffering from the challenges of working not only in our current system, but also during the era of COVID. Next slide. So this came through the thinking and therefore a planning committee led by Neil Busses and Tim Brigham. You can see that Pam Cipriano, Jennifer Bickle, Sarah Delgado, Art himself, and Julie Cease were part of the planning committee. You'll hear they put in a tremendous amount of work along with our NAM staff and partner with 3 institutions that you'll hear a lot more about to understand, share the lessons, and to say, how can we all help today? Next slide. For those who are not familiar with the collaborative, let me just quickly tell you about who we are. Next slide, please. So we launched in 2017. And the collaborative brings together many organizations who care about this issue. And we have these 4 goals: raising visibility of burnout, depression, moral injury, and suicide, improving the understanding of challenges to well-being, advance evidence-based solutions that improve patient care by caring for the caregiver, and lay the foundation for long-term culture change. Next slide. So we've done a lot of work in this last 5 years. Can you go back to the slide before, please? And that includes, of course, the issue of addressing stigma, looking at the visibility of burnout. So we have 210 network organizations, 150 commitment statements from organizations, numerous publications, and we actually have a series called Breaking the Culture of Silence, being able to, for the first time, for people to speak up, as Art just did, and having stakeholder meetings, Art showed in public disclosure. On improving the baseline understanding of challenges, we have a conceptual model to understand the factors influencing well-being and resilience. We have discussion papers on what are the drivers of burnout, interventions to address them, and we have a knowledge hub, which allow people to have information access online. On advancing evidence-based solutions, we have engaged CMS to align E&M coding and documentation strategies. We have worked with the Federation of State Medical Boards and now a consortium of licensing boards to provide guidelines and disclosure of physical and mental health conditions, and of course, engaging the EHR vendors to make modifications. And finally, laying the foundation of long-term culture change, we certainly have influenced the trend of chief wellness officer integrating well-being into health profession education, and many organizations are measuring well-being. and with a plan. So all that is great. Next slide. So why are we here today? We're here to amplify your voices. Your voice is so important. Your well-being is so important to us. And we want to be not only to amplify your voice, but also be your voice. I want to hear from you throughout this meeting. I'm talking about clinicians, frontline workers of care, particularly in session 3. And we may reach out to you after the meeting to continue our work to see how we can bring your voices to a larger platform to make a change. You know, it's never been more crucial for us to listen and to amplify the voices of frontline workers, particularly during COVID. You have been under enormous stress and trauma for 2 years, and even then before the pandemic. And recent acts of violence against you and your peers have brought many to breaking points. And of course, many have left healthcare workforce altogether. Now, back in 2021 in April, Vivek Murthy, who's with us today, the Surgeon General, and us reached out to a network of you and received over 500 responses on the effects of pandemic and your personal and professional lives. We share those solutions, we share those information and create the solutions. And today we want to do the same and to take and get back to many of you to make sure your voices are heard. Next slide. And so, first of all, we wrote a statement supporting all of you. Here's what we said. We all agree that dedication to caring for others shouldn't come at the cost of one's health and well-being. We must strive to shift from this reality to one where every healthcare worker able to experience joy in the workplace and knows that they are valued. You are valued, no question, from our point of view. Next slide. And of course, the work in 2022 have been focusing on how to bring tools to front lines through Research Compendium website, to highlight issues and solutions to administrative burden, and to engage health systems to health wellness action plan, addressing the challenges and sharing your pathways to solutions. Next slide. And of course, our work is not done. We have a lot of work to do. We're working with you acutely, but also long term. We're working as a collaborator to develop a national plan that will support your well-being, that is built on the 2019 consensus report about systems approach. But importantly, we look at a practical, actionable plan for national stakeholders now and also in the long run. And this national plan, which we hope to launch in the late summer, will begin to address many of the issues that everybody, the stakeholders, must take on to address this issue. So we're working with you acutely now and also the long run. We're committed to doing this. Next slide. So today's meeting will highlight the individual level stressors in the context of COVID-19, institutional level challenges and opportunities to support workforce well-being, and national levers for improving workforce well-being for the pipeline of healthcare workers is stemming the shortage. Now, I would point out to you very clearly that we have all of you, frontline workers and leaders and C-suite, and also everybody in this meeting. I see that we have now about 500 participants together to talk about the issue, to find solutions together. You matter to all of us. Frontline workers, we want to support you and want to do the right thing. My final slide, please. CME credit. This is done through Stanford Center for Continuing Medical Education. It's done together with ACCME, the Credit Council for Pharmacy Education, and American Nurses Credentialing Center. So thank you, and you can certainly write up your CME. And so it's my pleasure and honor to turn it over to my fellow co-chair, Vivek Murthy, to kick off our keynote fireside discussion with several leaders of clinician workforce well-being movement. Vivek, over to you.
Well, thank you so much, Victor. for the kind words that you just shared and for your leadership of this broader effort. As you mentioned and others have alluded to in our discussion today, this is really an issue, that of burnout in our profession, that is timely. It's one that has been building for years, but I also believe that we have an opportunity right now to seize this moment to do something different for health workers across the country who have been struggling for too long. There is a window of opportunity here where the public certainly focused or more open, I should say, to focusing on these issues than they've ever been before. And if we don't take this opportunity to lay out a path forward and to take action to move change forward, then I worry that we will lose this opportunity. The big difference I think that public support can make is to make sure that this isn't just a niche issue that people see as just something that healing professions have to deal with. It's something that the entire country has a vested interest in addressing. And so I'm glad that we have so many wonderful speakers with us today to help explore this topic. I would love to turn it over to the first speaker, to Michelle Hood, who will go through a few of her points and then and ask a few questions. And then we have several other speakers after Michelle: Deborah Howery, one of my colleagues from CDC, Rachel Villanueva, Beth Wathen, and who will also be sharing some remarks and asking questions as well. So with that, let me turn it to Michelle.
Thank you very much, Dr. Murthy, and good morning, everyone. I'm speaking to you today on behalf of the American Hospital Association, but also as a member AHA working closely with the National Academy of Medicine on this issue. So as the COVID-19 pandemic begins its third year, America's hospitals and health systems face profound and accelerating workforce challenges. Hospitals across the country continue to report critical shortages of nurses, physicians, and other vital healthcare professionals. Furthermore, many healthcare workers are suffering from the stress and trauma of caring for wave after wave of COVID-19 patients, exacerbating burnout. A 2021 Kaiser Family Foundation Washington Post survey found that nearly 60% of healthcare workers had experienced impacts to their mental health stemming from their work during the pandemic, and nearly 30% had considered leaving their profession altogether. In addition, the pandemic has compounded the healthcare workforce's long-term structural challenges. Federal data shows that the nation could lose 500,000 nurses by the end of 2022, bringing the overall shortage of nurses to 1.1 million. Yet nursing schools had to turn away more than 80,000 qualified applicants in 2019 due to lack of faculty or training sites. Data from the American Association of Medical Colleges indicates that 1/3 of currently practicing physicians will reach retirement age over the next decade, and projects a shortage of up to 124,000 physicians by 2033. In addition to capacity challenges, hospitals and healthcare workforce face an ongoing evolution in the healthcare needs of the nation, stemming from an aging population, rising chronic conditions, and behavioral health challenges. There also remain significant opportunities to optimize care delivery models, to leverage the use of technology, advanced analytics, team-based principles, and other emerging approaches. Hospital and health system leaders have expressed a need for better supply and demand data to forecast workforce needs more effectively, to reimagine training and educational models for both new and existing healthcare workforce, and to address new leadership skill requirements to adapt to this changing and challenging environment. To provide direction and advice to the AHA team, the AHA board recently established a board task force on workforce composed of members of the AHA and the AHA-affiliated American Organization for Nursing Leadership boards of directors. This task force is meeting on a regular basis and is addressing many of the challenges that we heard from our speakers already today, including creative staffing opportunities, well-being and violence prevention, stabilization and retention of our existing workforce, data, care model redesign, the use of technology to extend care, leadership training and development, working with our academic partners to build the educational pipeline, workforce analytics, and workforce strategic planning. The AHA recognizes that none of the solutions to the current crisis or the future workforce needs will be simple or singular, and many approaches implemented now will take time to bear fruit for meeting future needs. In addition, hospitals and health systems cannot do this work alone. We are very interested in partnerships across health, academia, and other stakeholders in order to address these challenges. My questions for the Surgeon General are two. First, do you foresee any new or expanded public-private partnerships to address the healthcare workforce challenges?
Well, thank you for that question, Michelle, and also just thank you to you for all of your leadership and your role as EVP and CEO of AHA. I know you've been a champion on the issues around clinician well-being. I think what you're bringing up regarding partnerships is essential. And one of the, I think, areas where the National Academies has been forward-leaning has been in building the collaborative to bring people and organizations together across disciplines, recognizing that to address well-being and burnout, we're going to need strong partnerships. And that is going to continue to be true going forward. I think in addition, though, to having hospital systems, nursing and medical associations, and educational institutions involved, we also need to ensure that technology companies and payers are part of these partnerships as well. We know they have extraordinarily important roles to play. We know payment shapes a lot of what we do and where time and attention goes, contributes also in some cases to to administrative burden. But we also know that tech is increasingly important, not only the EHRs that we use, but the technology we could be developing to make the work of clinicians more efficient, more streamlined, and to enable them to take better care of patients. So these partnerships will continue to be critical, and government is an important part of this as well. I want to make sure I underscore that. One of the reasons that I have been working closely with Victor and with Daryl and with Tom as a co-chair of the collaborative, despite my role in government, is because these collaborations are exactly what we need between government and the private sector. There are agencies within the federal government that have already done a lot and are going to continue to do more to help invest in addressing burnout. HRSA, Health Resources Services Administration, which many of you are familiar with, works on a lot of workforce-related issues, has actually increased loan repayment by more than 27% for people who are practicing in underserved parts of the country. And this has actually resulted in more than 23,000 more healthcare workers now receiving a loan repayment support for their work. So we're going to continue to build these partnerships because ultimately what we're trying to do is drive toward better systems, better support, and better culture in our healthcare systems. And these partnerships are going to be critical to doing that.
Thank you for that. My second question, you really given me a good segue there because you mentioned a lot of work that's planned or ongoing, both in the public sector as well as the private sector. So how will the federal government coordinate disparate efforts from multiple agencies to Congress and others on these issues to assure efficiency and effectiveness?
Yeah, and that's also a really important question, one that I began, Victor and I remember began having conversations about this even before I was serving in government, just recognizing this is a moment where we needed everyone to step up, including government. A few things that I would say here. One is that we are already, have been having a number of conversations internally within the federal government about how best to coordinate the efforts that are happening across agencies. I mentioned HRSA, but there are also efforts underway at certainly within my office, the Office of the Surgeon General. The CDC has been working on issues related to burnout for some time now. And the president recently in his State of the Union address and in the sort of documents that came out thereafter following this speech laid out the importance of us addressing the well-being of our healthcare workers. And that has really added more lift and urgency to the efforts that all of us are engaged in across the administration. So what we do need, I believe, as a country is to have a blueprint for how we address well-being among our health workers, a blueprint that lays out not only a clear vision for what we need to do, but also the roles that different entities need to play inside government and outside government, and then brings people together to help play that role. That's certainly a place where our office is doing a lot of work on that blueprint in collaboration with our sister agencies across government. And it's a place where we're excited to work together with the national academies and with many of you as well in the months ahead. So we'll have more to say about that blueprint in the months ahead, but this collaboration and the role, especially the public-private sector, couldn't be more important.
Thank you, Dr. Murthy.
Well, thank you. Thank you so much, Michelle. I want to turn next to Deb Howery, who is our acting principal deputy director at the CDC. I've known Deb for a long time. She has been a long-time public servant, has made incredible contributions to areas that you will recognize, from gun violence to the opioid epidemic to others. So without further ado, let me turn it over to Deb.
Well, thanks so much. And it's great to be on this esteemed panel with everyone today. I echo what Michelle said about, the health workforce has really been lauded as heroes for their commitment to fighting COVID-19. But the toll of the pandemic has certainly been a heavy weight on the shoulders of our nation's health workforce. And personally, I've heard throughout the pandemic from many of my former ER colleagues about all the burnout and stress that they were facing. On top of that, our frontline health workers, including clinicians and public health workers, have faced burnout and a heightened risk for mental health symptoms such as anxiety, depression, and PTSD. The Association of State and Territorial Health Officials highlighted the extreme backlash that the public health workforce has faced as a result of COVID-19 policies, which has contributed to what people have talked about with all of this, the increased resignations. Specific to public health, many public health officials have experienced personal threats in the form of angry and armed protesters at residences, vandalism, and harassing telephone calls and social media posts. And in a survey of public health workers, about 12% of respondents said they received job-related threats, and about 23% felt bullied, threatened, or harassed because of their work. For the public health workforce, similar to healthcare workers for sure, also the working long hours, the limited opportunity for time off, and inadequate compensation were stressed. When you look at the institutional level, the public health workforce is often our first line of defense against many disease outbreaks and other health threats. Yet there's been decades of underinvestment in the public health workforce with shrinking numbers and capacity, which, as we saw, left the nation vulnerable to threats such as COVID-19. In the past decade, over 50,000 public health jobs were cut, and thousands more are preparing for retirement. In fact, at CDC, about 1/4 of our staff are now retirement eligible. We've also seen health officials retire, resign, or been forced to leave at record numbers due to some of the state emergency powers or lack of support by lawmakers and government leaders. But we're at a time of great opportunity. It's certainly not as simple as just having money to hire. We also need to modernize antiquated hiring systems and really look at comprehensive workforce planning. And because of this, I think we must focus on professional development, mentorship, and training for strategic and technical skills, work with academia to give more students applied learning experiences to better prepare them for jobs in public health, and really strengthening recruitment while focusing on diversity and health equity. Now is really the time to leverage the lessons learned and best practices that have come out of the COVID response, and really to support building back our health workforce. And then just finally, there are a number of national levers and opportunities to improve our health workforce, its well-being, and the path to careers to improve the shortages. At CDC, we're working to improve workforce well-being and enhance the pipeline of workers. The American Rescue Plan has enabled the expansion of some of our CDC training programs, such as the Epidemic Intelligence Service and the Laboratory Leadership Service. We're also now able to expand our student loan repayment program for those accepted into these and other fellowship programs. And we're working with the Corporation for National and Community Service to develop a new U.S. Public Health AmeriCorps program that will place over 1,000 health workers per year in underserved communities to build up the public health workforce. And finally, we have the Public Health Hero, or Public Health Hope, Equity, Resilience, and Opportunity Program, which will be supporting a culture of well-being and resilience within state and territorial public health agencies. And this will really implement tools to address mental health and burnout and to build resiliency. So this increased investment in the health workforce is one of the first steps to build back our health workforce better, stronger, and more prepared to prevent the next pandemic. And all of you are such an integral part of that health workforce, and your well-being is essential for its success. So Dr. Murthy, what I'd love to hear from you, I know that we always want to focus on protective factors and not just risk factors, but what are some shared protective factors we can put in place for public health workers and clinicians?
Well, thanks, Deb, for that overview. And I just want to underscore something very important that Dr. Howery said, which is when you heard the statistics she shared about the large portion who have been public health workers who have been bullied or the subject of verbal or physical altercations. When you actually look at the impact of that on the mental health and well-being of public health workers, one of the surveys CDC did around this time last year showed that 53% of public health workers were actually reporting at least one mental health condition in the last 2 weeks, either symptoms of anxiety or depression or PTSD or suicidal ideation. These are incredibly high numbers. And when you've seen these numbers again and again and again, you can almost become numb to them. But it's worth underscoring that this is not normal. That this is not what a workforce can and should be experiencing, and certainly not what the mental health of such a critical workforce should be. As we think about protective factors, I want to come back to something I mentioned earlier, which is I do think that there is, while the solutions are somewhat different for public health workers and for healthcare workers, I think that the principles are similar, which is that we need better systems, we need better support, and we need a better culture. When it comes to better systems, we need to provide healthcare workers public health workers, with better tools. Deb mentioned that when the Great Recession hit in 2008, budgets were slashed across the board, but when the economy recovered and budgets were replenished, public health budgets were not replenished. And in fact, the work continued to expand with fewer and fewer resources. And of course, we are paying the price for that in part during the last 2 years during the COVID-19 pandemic, where we didn't have the public health muscle that we needed to the full extent. And so the burden fell on fewer and fewer public health workers to carry that load. But better systems are absolutely critical. And that's not just better technology. It also means better connections with the clinical system, the healthcare system, with government as well. We have a very fragmented public health system here in the United States, which means that data gathering is difficult, which makes it in turn harder to understand key lessons and target resources appropriately, which means regions don't get the help that they need. When it comes to better support, though, this is a place where both for public health workers and for healthcare workers, we need to enable them to have better access to mental health care, and do so not just by ensuring that they have health insurance, but ensuring that the insurance actually covers mental health services. Even when those are present, many healthcare workers and public health workers find that they can't make an appointment with someone. They have the same problem the general population has in terms of availability of mental health service providers, which is why it's actually so important that we think creatively here about how do we use telemedicine, telepsychiatry, telemental health services, and actually bring them on site to people. I was actually talking to a group of health workers recently who were saying, rather than, and then a number of them actually worked in the evenings and night shifts, and they're saying rather than expecting us to somehow go out there and find a provider, get on a 6-month waiting list, and eventually during daytime hours when we're supposed to be sleeping, make our way there, why don't we have virtual services available on site for health workers so that we make it easier to give them something that they increasingly need. And then the last one is a better culture. And what I mean by this is that, and I think many of us probably recognize perhaps in our own experience in the health professions that the way that our professions have often defined strength has been based on your ability to suck it up, to not show that you're hurting in any way, to take on more and more workload, sleep fewer and fewer hours, and still somehow get the job done while you're, by the way, publishing papers on the side. That is not a realistic definition of strength. I would say it's not a healthy definition of strength, but we still struggle from strength being defined in that way. And so you can't legislate, a change like that. That has to be a cultural change that leaders not only talk about, but demonstrate, that systems ultimately support. Building a culture, I think, is the most important part of how we're going to get through burnout in the years ahead, building a better culture. And without a better culture, all of the supports we may put in place may not be fully as useful. If we have, for example, better mental health care access, but we have a culture that doesn't support people actually taking the time to take care of themselves, people won't avail themselves of those services. And so that's why the culture and the systems change really go hand in hand. Well, thank you, Deb, for that. I want to go next to Rachel Villanueva, who's a clinical assistant professor of obstetrics and gynecology at the NYU Grossman School of Medicine. Rachel, let me turn it over to you.
Perpetual muting. After 2 years, you think I'd be much better at that. Thank you so much, Dr. Murthy, and good afternoon, everyone. As it's been said before, it's really an honor to be part of this panel and have this discussion, and really for me to be able to highlight something that I think is unique in the issue of clinician well-being, and those are the challenges faced by underrepresented healthcare workers. And while the National Medical Association represents Black physicians and patients, I think these issues transcend all disciplines. As COVID-19 burdened all healthcare workers of color were disproportionately impacted personally, in the disproportionate numbers of people in their own community affected, and professionally as well, exacerbating inequities that had already existed. At the time of NMA's inception in 1895, Black physicians were barred from being part of organizations such as the AMA and getting credentialed. And so to survive, they created their own organizations, their own hospitals, and their own medical schools. And the disparate outcomes in communities of color were rooted in those Jim Crow laws that, although were not so distant in the past, really still impact us very much today. In the early 1980s, the Flexner Report, as we very well know, closed all but 2 medical schools, Black medical schools in the United States, significantly hampering the number of Black physicians that would be educated. It's been estimated that there would have been over 27,000 Black physicians in the workforce now had the Flexner Report not closed those medical schools. Currently, we African Americans only comprise 5% of physicians in the United States, although our population is nearly 14% of the population. And over the past 40 years, we've done little to diversify the matriculants of medical schools. I think it's increased about 2% since 1980. And we know that this will not produce a racially and ethnically diverse workforce that we need to take care of the population of our United States. That we know by 2044, by some estimates, the majority of Americans will be of a minority group. And we know also that underrepresented workers disproportionately take care of underrepresented patients and in under-resourced areas. And we know that these things can lead to increased burnout and stress. But we also know that patient-provider concordance has been well documented to improve patient compliance, decrease disparities, improve outcomes, and is needed to achieve a more equitable healthcare system. Calls for diversity in improving population health have been known as far back as the Hengerer Report in the 1980s. We know that diversity of our educational system, our healthcare delivery system are all needed to address workforce shortages, to increase the diversity of research, to increase cultural competency, and we must actively and intentionally address the lack of diversity of our healthcare providers today. But additionally, we know that systemic and structural racism, discrimination, and bias are also a part of our healthcare system, and that affects patient experience, perception, outcomes, and support the inequities that continue to exist for communities of color. For students and providers of color, these similarly affect their ability to train, to be educated, their workplace environment, Racism, we know, is a public health issue. It's systemic, it's pervasive. But to think that the people that work and are trained within the system are not subjected to its ills would be naive of us. So we know that this is something we also need to intentionally address. Medical students have identified race as a significant contributor of distress in medical school experiences and are 5 times more likely to report race adversely affecting their training. Minority students leave STEM, 1/3 of them, because of perceived discrimination and bias. Racial and ethnic minority physicians experience many aspects of workplace discrimination, harassment by both their superiors, coworkers, and even patients. There's bias, racism, stereotyping, microaggressions. All of these lead to feelings of isolation, self-doubt, the imposter syndrome, which negatively affect and increase stress and burnout for healthcare workers of color. We know that Black and Hispanic individuals in STEM fields also report that race is a factor in negatively impacting their hiring, promotion, and career advancement. So moving forward, we must tackle these difficult issues of diversification of our workforce, addressing the unique challenges and experiences of students and workers of color that are ethnically and racially diverse. We must place emphasis on holistic approaches to admissions. We must stress retention as well as recruitment. We must, at the institutional level, address the systems that support discrimination and bias and actually have anti-racist policies for our institutions. And we must, as Dr. Murthy was saying, create a culture that is not only diverse, but inclusive as well, requiring mandatory bias mitigation education. And finally, investing in professional development, investing in partnerships with historically Black colleges and universities to line that pathway and pipeline for of underrepresented minority students, to partner with minority associations such as the National Medical Association, and to invest in communities of color as we try to make our healthcare system more equitable. We know that physician burnout and shortages will only continue to disproportionately affect access and care for communities of color. In 2017, it was this Action Collaborative that noted that we are not aware of any studies that have explored ethnic or racial differences in the prevalence of burnout among practicing physicians. But we clearly see that there are many reasons why stress and burnout would disproportionately impact this community. We need to have more data and research to address the complexities that affect underrepresented in medicine physicians and workers. Finally, just to say that the viability of the African-American physician is at the heart of the mission of the National Medical Association. Since its inception, it was why we were part of the reason why we were founded. And while stress is experienced by all healthcare workers, and we've seen that unfortunately very well from the COVID-19 pandemic, we must specifically address and identify those unique stressors that are experienced by marginalized groups in order to create a truly comprehensive national plan that promotes a positive work and learning environment and produces that cultural shift needed in order for our healthcare system to benefit not only the patients, but those individuals that work within it. And so my question for Dr. Murthy, fellow Yaley, is going to be, how do we support physicians of color? And this is an issue that is on the minds of our membership very much so. How do we support physicians of color who are being disproportionately profiled and targeted by state licensing boards and hospital boards?
Well, thank you for that question. Nothing makes you feel, I think, less valued than being targeted for disciplinary actions disproportionately. And unfortunately, a lot of people are feeling that right now. I know that the Federation of State Medical Boards last year created a task force on health equity and medical regulation. I think that it's an example for affirming their commitment basically to addressing this type of discrimination. But what we also have to do, though, is making sure that it's working, that we're holding ourselves to account. To me, that involves several things. One, it means making sure that we're collecting data on how people are being treated and whether there is in fact disproportionate treatment taking place. A lot of times we don't see what's happening because we don't have the data. I think the second thing is we've got to be transparent with that data. We've got to make it such that people can see what's actually happening. To me, transparency is so tightly linked with accountability, right? If we don't share openly what's happening, people can't see the discrepancies, then we are less, I think, able and compelled to hold ourselves accountable as a healthcare system and a healthcare culture to ensuring that things are equitable. I think the other big piece here, though, is representation. This comes back to something you were referencing earlier, which is when you have a system where people are underrepresented, especially in leadership, there's a greater risk of discriminatory practices happening, whether even with the best of intentions. And so again, this isn't about commenting on or judging what's in their heart. It's about saying that we have, as systems, as individuals, certain biases, certain vulnerabilities, and the way that we ensure that we're serving everyone is to ensure that there is adequate representation, like in our systems. That means recruiting in clinicians who look like the country they're seeking to serve. It means also making sure at the highest levels of leadership, whether that's on our boards, on our executive teams, on our clinical leadership teams, that people of color are also well represented there. So these are, I think, some of the steps we've got to take. We've taken some of those steps in some places, but not necessarily in others. I think as a profession, we have to ask ourselves the question, how do we measure what matters and hold ourselves accountable to actually making progress while giving and creating space for the voices of those who have traditionally not been represented as well in the corridors of medicine. That's part of not just the systems change, but as I think of it, the culture change that we're talking about that has to take place.
Thank you so much. I really appreciate the opportunity. I really appreciate what your words and your commitment to making a difference and to making substantive change for communities of color and for physicians of color. I really do appreciate that. Thank you.
Thank you so much. And finally, let me turn to Beth Wathen, who's our president of the American Association of Critical Care Nurses, president of the board. Thank you so much for being with us today. Let me turn it over to you.
Thank you, Dr. Murthy. Thank you for this opportunity to participate in this important and relevant dialogue today. No question, critical care has been one of the most impacted areas during the pandemic. AACN represents and knows the practice of more than 500,000 nurses working in acute and critical care, nearly 130,000 of whom are our members. Because our time is limited, I'd like to make 3 key points. These points address not only the individual and institutional level stressors nurses have faced, but fortunately, they illuminate for us the way forward as we emerge from this pandemic. If we listen keenly to what nurses are telling us, many of the answers are embedded there. Despite critical care clinicians being accustomed to severe illness and death, the pandemic brought this to unfathomable levels. Add to this the physical barriers of PPE, lack of families, and isolation, and the challenges become more immense. Importantly, what we saw in the later waves of COVID and what brought this extreme situation to a head was the lack of staff in many locations to even provide appropriate care for their patients. This is my first point, that acute and critical care nurse staffing has deteriorated to a point that in many locations is dire. In consistent reports from nurses in our community, staffing levels were marginal pre-COVID. There is a point past which safe care simply cannot be delivered. The number one concern and source of moral distress that we're hearing from nurses is that many units are at that point of not having the human resources needed to deliver safe care, even as COVID numbers ease up across the country. That's why AACN is looking at our role in understanding the minimum level for safe patient staffing in critical care settings. Secondly, we are very concerned about the health of the work environments in which care is being delivered. AACN's Healthy Work Environment Standards, published over 15 years ago, delineate the 6 components that work environments need to be healthy and effective, including appropriate staffing, true collaboration, authentic leadership, and effective decision-making, which includes having nurses' voices at decision-making tables. Our most recent research conducted in 2021 shows that work environments have deteriorated in acute and critical care areas, and that an alarming number of nurses intend to leave their current jobs imminently. This longstanding issue is now at a crisis level. And to my first point related to staffing, addressing staffing without improving the work environment does not improve patient outcomes. This is not an either or, rather it's a both and situation. And an assessment and tracking of the health of the work environment should be mandatory. And finally, everyone participating in this conference knows that the disparity in compensation practices during this pandemic for nurses in hospital settings has fueled an understandable rift and focus on fair and equitable pay practices. This crisis presents an opportune moment for all of us involved in healthcare leadership to look at how to avoid this situation in the future. Now is the time to authentically look at fair, flexible, equitable, and transparent compensation packages for loyal and dedicated staff to avoid this rift in the future and to stop the current exodus of clinicians from the acute care environment. We've never before seen nursing and therefore healthcare in a crisis of this magnitude. If we embrace this crisis as an opportunity and work together, we have an unprecedented chance to transform our system and begin to put practices in place to assure this dire situation does not happen again. Thank you. And my question for you, Dr. Murphy, staffing is a top of mind concern for nurses, and the trust that they have that administrators will provide for appropriate staffing has been broken in many settings. How can trust begin to be restored so nurses and other leaders can move forward together in true partnership on this dilemma?
Well, Beth, thank you so much for what you said. I couldn't agree more with how you framed some of the needs. I'll just say, particularly on the staffing front, the number of stories that I've heard, and I'm sure many of us have heard in the last 2 years about nurses who were put in situations where they had to care for, frankly, an unsafe number of patients, a greater number of patients than one could possibly care for. I've just lost track of the number of stories, and it doesn't just have a bad impact on potential and patient outcomes, but the moral distress and injury it causes to the nurses themselves who are put in that situation where they're trying to do their very best, but just can't humanly deliver all the care that's needed. The consequence of that also lasts for a long time, and I worry we don't fully account for that price, when we create our staffing ratios. When it comes to trust, though, I'm glad you brought this up, because trust is the glue that will ultimately hold our healthcare system together. And because we really do need a shift toward more collaborative approaches, team-based approaches to care, that trust becomes all the more important. I do worry that during the pandemic that there have been rifts, as you talked about. There have been many folks on the front line who feel like the administrators and leaders in their institutions maybe don't fully understand what they are going through, what they're grappling with, what they need. And as we come, through the pandemic, we're not through it yet, but as we hope to come through the pandemic, we've got to think about how we repair that trust. I tend to think about, in many ways to think about trust. I think about it in a fairly simple way, although this is hard to do, which is to build trust. I think you have to listen to people and truly listen to them and hear what they're saying. I think number two, you have to commit to taking action to improving their circumstances. And third, you have to actually deliver on those, because one of the worst things that breaks promise, ruins trust, is breaking promises. And I say that even though it seems simple, it's so compelling to make promises that we can't keep in the face of a crisis. But this is again but that damages trust in the long term. This is, I think, actually what we need to do, like in the healthcare professions. One of my worries with not just what's happening in the healthcare professions, but more broadly in the country, is that we are in such a, we feel so urgently that we have to get through this pandemic that people want to just flip back to 2019 and how we were before the pandemic. But the truth is, we've been through the kind of trauma that you can't just flip the switch on or walk away from. Like, we have to reflect on it. We have to understand what worked, what didn't work. We have to make sure people who experienced the trauma of this pandemic have the chance to be heard, and that we understand their experiences and then use those to reflect and a path forward and a strategy forward. And we've got to make sure that their voices are at the table, because again, to lay out a path forward that doesn't actually include those on the front lines and leadership is, I don't think that that's going to engender the kind of trust that we're talking about. I don't think it'll generate an effective outcome. I think for many people on the call here today, that probably seems like a no-brainer to you, but there are still many institutions in our country, healthcare institutions, which don't have our frontline health workers actually represented adequately in rooms where decisions are being made, and certainly in administrative leadership. So those are some steps I think we need to take urgently to improve trust. I'm reminded of these lessons by my 4- and 5-year-old and by my kids every day, who kids have so many life lessons they teach you, but when I don't listen to my kids and they don't like it, they don't trust that I really get what's going on. When I don't actually commit to being able to address like some of the things that they were upset about, they also don't trust me. And when I make promises that I can't keep, when I don't deliver, that breaks trust as well. So they're teaching me in their own way how we rebuild trust, but I think that there are broader implications for our healthcare system too.
Thank you,
So,
Dr.
of course, thank you so much, Beth. Let me turn it over as we shift from this section. I want to turn it over to Dr. Jennifer Bickle, the Chief Wellness Officer at Moffitt Cancer Center, and she will lead our next session.